So I'm John Parker. I'm one of the intensive care consultants based at the LRI, in case people don't know who I am. I've been involved with sepsis for many years, and I've been the Trust Sepsis Lead up until recently for about 10 years. So yeah, in ICU, obviously, sepsis is the driving pathology for probably a third to a half of all of our unplanned admissions, and is a big issue for some of our patients that we have when we're on the ICU as well. So what we're going to cover today really is talk about why it's so important, some of the definitions around sepsis and septic shock and the risk factors associated with developing sepsis. I'm going to wrap this up in a clinical case that we had a few years back, and that will help, I'm sure, frame the initial management ICU care and the kind of problems that these patients get. And by all means, hopefully have some questions afterwards. It's going to be really difficult for me to do this as an interactive thing, and I apologise for that, but I'm happy to chat about anything at the end. What this isn't is a talk of the pathophysiology of sepsis. It's very much a clinical presentation, and nor is it a detailed evidence-based medicine appraisal of all the evidence. We would need several days of discussion for that. So why is it important? This is UK Sepsis Trust data, but there's about 250,000 cases of sepsis every year, 50,000 deaths, an estimated 15,000 preventable. What does that boil down to in Leicester? That's about 4,000 a year, with about 800 to 1,000 deaths within LLR. Cost of the economy is about 16 billion, is probably going up, which is roughly 10% of the entire NHS budget as an equivalent. Not only mortality, but morbidity is a big issue, with physical debility, long-term renal replacement therapy, limb loss, some psychological problems, particularly post-traumatic stress disorder. The guy on the right is a guy called Tom Ray, who about 25 years ago had a serious bout of sepsis, was treated in Peterborough, and lost all 4 of his limbs as a consequence of that, and some significant disfigurement. And he's now an active sepsis campaigner. The way we manage sepsis is very closely monitored by external organisations. The CQC, rightly or wrongly, use it as a barometer of the quality of acute care, and will often look in detail about how we're managing sepsis and the way we're performing in certain key performance indicators, such as the time to delivery of antibiotics. NHS England will also watch our data very, very closely and issue our chief executive with communications if we're not performing well. Courts, particularly the coroner's court, as you'll see in the clinical presentation, are becoming increasingly interested in how well sepsis is managed, and are very keen at times to offer narrative verdicts when care has been found to be suboptimal, with suggestions of better practice. So that's where we are, and that's why it's really important. I'm sure we all know that. So what I want to do now is delve into a clinical case which actually happened about 10 years ago, and very nicely illustrates lots and lots of the issues that crop up with patients, and outlines the clinical management of these sorts of patients in ICU. CR, she was a 35-year-old lady, had got 2 young children, I think both of them under 5, normally fit and well, and she had been suffering from what we could describe as a flu-like illness for about 4 or 5 days, but particularly having a cough, green sputum, a lot of fatigue, and increasing levels of breathlessness. She'd attended her GP on several occasions with this, not had a proper clinical evaluation, had no vital signs measured on either either assessment, and was diagnosed as having a self-limiting viral illness. Shortly after that, she also made a 999 call, an ambulance attended, and a long discussion occurred about her going to hospital, which she decided to decline. She was becoming increasingly fatigued and breathless, and was noted to have a heart rate of over 130 at that time. A day or so after that, she was then there was then a 999 call, and the paramedic crew attended, and she was in extremis, very drowsy. She was noted to have mottling on her legs and was becoming physically exhausted, and so was blue lighted to the emergency department. And obviously, when she arrived, looked extremely unwell. She was tachycardic with a borderline blood pressure, and there was obvious mottling extending up her legs. She had a very prolonged capillary refill in her hands, a slight increase in temperature, was very breathless, and the SATS trace couldn't really pick up any kind of level of oxygenation. It was really due to a poor perfusion. The most notable clinical signs are in the chest, with right-sided signs of she had bronchial breathing on the right side and reduced air entry. She had a chest X-ray, which we'll see a blood gas, venous blood gas with a very high lactate of 9, a metabolic acidosis. She was given some oxygen and given some stat fluids. Sent some bloods, which I've shown up there, and there's the chest X-ray, which kind of shows a dense right lower lobe consolidation. What's notable on her bloods was a very low white cell count of 3.2, and a significant acute kidney injury with a creatinine of over 300, and a very high CRP. At that same time, she had venous plug cultures sent and was started on IV carmoxyclav and erythromycin, and we were contacted for attendance, which we went down and saw her immediately. She was given a further litre of fluid, and a lactate was repeated, and that had gone down ever so slightly to 7. We brought her up to ITU, and because she was in such extremis with her breathing, she was intubated and ventilated and had lines inserted. At which point, as per usual, her cardiovascular system crashed, and she needed increasing amounts of vasopressors. We escalated her IV antibiotics to Tazocin, and that mottling that was noted previously was it seemed to be extending into her groin. Passive leg raised tests suggested that she was fluid responsive, so she had further boluses of IV crystalloid given, but was on increasing amounts of noradrenaline. She was becoming increasingly hypoxic, and we needed to essentially move towards reduced levels of tidal volumes, permissive hypercapnia and hypoxemia, and increased PEEP. She had also become anuric. She had passed no urine since coming into hospital. With that profound lactic acidosis, so a vas cath was cited immediately, and she was put on a filter. We started on some hydrocortisone, and because she was becoming refractory to the noradrenaline, she was given some vasopressin as well, because her MAP was less than 60. So obviously this lady was obviously extremely unwell, and some very difficult conversations were had with her husband during that afternoon, which was a Saturday, and we were very guarded about her prognosis, because she looked like she was going into multi-organ failure. Overnight she deteriorated further. I think we did a FICE echo, which indicated an evidence of an impaired LV, but she looked well filled. She's had some adrenaline added, really in desperation, but she continued to deteriorate despite all the support that we were giving. We'd added in some bicarbonate as well, but her lactate continued to go up. The mottling that we'd noted the previous day had extended onto her abdomen, chest wall, onto her neck and face. Her platelet count, which was about 199 when she came in, had dropped down to 41. And that next day, despite all the support that we were giving, she died. We then received the day after that from the venous blood cultures confirmed that she had a group A streptococcus in her blood. This went to the coroner, really on the basis of concerns around what happened in primary care. And this case coincidentally happened about 5 to 6 months after the whole of the NHS, including primary care, have been sent details about the assessment of patients with sepsis in GP surgeries and about certain actions that should be done. And unfortunately, the GP surgery that she attended hadn't carried out any of those actions, and the coroner issued what was then a primary care trust, Section 28, or prevention of further deaths request. And so the trust, the primary care trust, was then committed to driving up the quality of what they were doing with patients with sepsis. So that was a whistle-stop tour of a very tragic case that I think affected everyone that was involved with it, understandably. So I'll take a step back now. Now, normally in a group environment, I would ask you guys to define sepsis. I can't see you, but if there's anyone that wants to, in one sentence, to venture what sepsis is, then I'll be interested to hear. Okay, so what I'll do now is just move on to what we are still with, really, which is the Sepsis 3 definition from 2016. And in a short, punchy statement, this is a life-threatening organ dysfunction caused by a dysregulated host response to infection. And this kind of frames how we think about which patients have sepsis. Okay, how we work on applying this into clinical practice. So in clinical practice, the first thing you obviously need is a clinical suspicion of infection. Now, this is important that it's a suspicion and not a diagnosis, because often in a dynamic acute environment, you don't get that. You don't get absolute concrete evidence. So it's usually pulling together pieces of clinical assessment, maybe immediately available investigations, often not microbiology, which often takes days, as the clinical case illustrated. But you have to build up a suspicion. And then alongside that, evidence of organ dysfunction. Now, what you see there is various things that have been postulated in the past. SOFA scores, Q-SOFA, which came out with the original Sepsis 3 definition, which has now really been discredited. Red flags, which is what we're still using in this trust, but will be replaced very soon. SIRS, which comes from the old Sepsis 2 definition, is now gone. And News 2 greater than or equal to 5, which is part of the Royal College of Physicians definition. Some trusts around the country will be using that. We will probably move to something similar as per the new NICE guidance that will come on to. Any patient that has these two in combination, i.e. a suspicion of infection alongside the evidence of organ dysfunction, can be thought of to have a risk of mortality of between 10 and 20%. So these are a predefined high risk group. How that then translates into what we do in UHL currently is the clinical suspicion of infection alongside a red flag. And a red flag comes mainly from vital signs, and I'll go into those in more depth in a minute. But the important thing with red flags is that they're acute. Anyone with chronic disease, that has to be taken into account when you're thinking about these patients. So someone that's got chronic levels of depressed consciousness or doesn't pass urine, has got a chronically elevated respiratory rate or low saturations, i.e. in COPD, these should not be considered as red flags. Evidence suggests that patients with red flag sepsis have got a mortality risk of about 20%. So what about the patients that we should be concerned about in terms of those that have the risk factors? So taking a little step back, well, more and more I get worried about patients with diabetes. Here's a little statistic for you. 1 in 3 of all of the positive blood cultures in our microbiology lab are in patients that are diabetic. So we clinically see huge numbers of patients with sepsis, and it's so common that a key driving factor to this is diabetes, and also the severity of it. So patients with things like necrotizing fasciitis, or the emerging thing of emphysematous pyelonephritis. These are exclusively patients that tend to be diabetic. So that's a really big one. The other group of patients, obviously, that we're seeing a lot of now are older patients and those with significant frailty, and they obviously are at risk of sepsis, and this will often be a life-ending event for them. Then obviously patients that are immunocompromised, and that might be due to disease or drugs, so hematological malignancies or chemotherapy or steroids, but also the more subtle changes in immune function, particularly patients with significant alcohol use, or those that maybe have had a splenectomy, which can be slightly more obscure causes of immune dysfunction. Patients that have had a severe medical or surgical illness, or trauma or burns, are obviously at risk. Patients that are pregnant or have recently been pregnant within 6 weeks are at increased risk, and children under 1. As I mentioned earlier, what are red flags? They are inextricably linked to early warning scores. So anyone that tends to score a score of 3 in one parameter on their early warning score almost certainly will have a red flag. So that will be a respiratory rate over 25, a need for oxygen to keep saturations over 91%, a systolic blood pressure less than 90 or a fall of 40 from their baseline, heart rate over 130. They haven't passed urine for 18 hours. That's not, obviously, urine output is not part of news. And if catheterized, less than 0.5 ml per keg per hour. And not alert on aqua poo. Now, this is a really important one because it's the only scoring part of news that is subjective. So what that means is that all the others are obviously a measurable number, but it's reliant on the observer as to how this score is attributed, and not by no coincidence, really, this is also the one that gets missed the most in patients that present with sepsis. So those that come in with delirium or new confusion, this is the one that we see when we look back that's been missed, and the opportunity to treat has been delayed. So the one thing I would suggest in this situation is a SQUID, which is a single question to identify delirium. And all this simply means is that you ask someone that knows the patient really well, a family member or a carer, as if their conscious level, their level of confusion is normal for them or not. The next ones, which are also really, really important and not part of news, and NICE guidance recently has focused on these a lot. Evidence of a purpuric rash. Now, I think we will often pick up on this. Mottling, I think, is less well detected, but mottled skin is a red flag. Ashen or cyanotic. Now, cyanosis, I think, in certain patient populations presents a difficulty as to whether or not that's a red flag or not, particularly in the respiratory units. And patients that are neutropenic or have had chemotherapy within the past 6 weeks are also red flags. So septic shock, so the more severe form of sepsis and carries a much higher mortality. I'll again sort of throw it open to the floor and give a few seconds for anyone that wants to be brave enough to come forward with a diagnosis or a description of what we define septic shock as. Okay, so a bit like we did with sepsis, it's again a suspicion of infection, but this is linked to evidence of hypoperfusion. And there are 3 elements to that. So this is hypoperfusion after adequate fluid resuscitation. So you need to have given at least 1 litre to 2 litres of crystalloid before you should really be making this judgment. But it's the combination of an elevated lactate above 2. It's actually a mean arterial pressure below 65, but because in most settings that's not measured, a systolic blood pressure less than 90, and evidence of organ dysfunction requiring a vasopressor. So windows of perfusion, this could be depressed conscious level, reduced urine output, poor peripheral perfusion, reduced capillary refill, that kind of thing, requiring a vasopressor. So not everyone with a low blood pressure necessarily needs a vasopressor. Their organ function can be just fine, and nor would they possibly have a high lactate. Equally, some patients present with really very high lactates, that they've got something completely different wrong with them. For example, they're post-ictal after a big seizure, and they're clearly not got septic shock either. So it's important to have all 3 of these components to formally diagnose someone as having septic shock. Now, the 2016 definition essentially reverse engineered this definition so that there was a mortality around the 50% mark. So these patients are extremely high risk of death from their sepsis. So treatment, as I'm sure you all know, involves the sepsis 6. And the sepsis 6 was described, or probably a good 15 years ago or so now. And its intention is to empower junior medical staff who are the first to assess a patient who they believe may have sepsis to do something which is going to change the outcome. And we can think very good about how we manage our patients in ICU, but the be all and end all of improving outcome from sepsis is what's done in those first few minutes of our patients developing sepsis and becoming unwell. So if this sepsis is recognized rapidly and treated rapidly, then you're much more likely to get a beneficial outcome in terms of reduced mortality, but also reduced morbidity, length of stay, problems going forward. So getting this right is so important. So what is it? The sepsis 6 is listed on the left, and then a bit more about fluid management in that early phase. So as you probably saw from the clinical case that I described, every element of the sepsis 6 was done in ED as the patient landed, which was exceptionally good care. So the first thing you do would be to give oxygen if the patient needs it, and that's generally if they've got saturations below 95%. You'd obviously be more cautious in patients with COPD. Then you take a series of blood, check a serum lactate, and do peripheral venous blood cultures and cultures from indwelling lines if they have them. The next element is to give an intravenous antibiotic. In patients with life-threatening sepsis, that should be given within an hour, and it should be an antibiotic that's targeted at what the likely source is. So in other words, an effective IV antibiotic. If the source is not known, then the broader the spectrum antibiotic that's required. In UHL, that traditionally has been meropenem, although we're looking tighter and tighter at this now and trying to be more targeted. This is a new element of the sepsis 6 relatively. Number 4, there should be within that first hour a senior clinical review. So this is someone graded at ST3 or above who can corroborate the clinical picture and take things on further if needed. The next element is to do with a fluid challenge. So this is particularly for patients with an elevated lactate above 2, or if they are hypotensive. So as you see on the right, the fluid challenge should be with crystalloid, and it should be of the order roughly of about 30 mils per kg, which for the average adult is around about 2 litres, and that should be given pretty rapidly. The first 500 mils to a litre or so pretty much stat, and certainly within 3 hours. That should be given. There is then a temptation to give more and more fluid. That may be on an individual patient basis indicated, but there is growing evidence to think about introducing an early vasopressor in patients that remain hypotensive after that initial fluid resuscitation. I'll come on to more of that in a minute. Obviously, measuring urine output, vital signs as required, as guided by the NEWS algorithm. Patients that should be referred to ICU, that we'd expect to be referred to us, anyone that meets the criteria for septic shock, obviously, anyone that has sepsis and that an elevated lactate of over 4, and that's sepsis driven. Anyone that requires more than 50% oxygen or has significant cardiovascular, CNS, and renal dysfunction. As I put at the bottom there, really, there's a growing consensus, and it's part of the Surviving Sepsis campaign now, to consider giving early vasopressors, and this would really realistically be in the form of peripheral noradrenaline. Now, we are set up in our emergency department to deliver that, and I would say that anybody that's been accepted for admission to ICU for management of their sepsis that is hypotensive after fluid resuscitation should be given peripheral noradrenaline before they're transferred in order to stabilize their cardiovascular system and raise their blood pressure. What we know is if we don't do that, there is quite a delay in getting a central line in and x-rayed and vasopressors up, and there can be several hours of significant hypotension putting patients at risk. So we are set up by the DART service to be able to give peripheral noradrenaline in the emergency department to patients that need it. This is only for patients that have been accepted for escalation to ICU. Okay, so we want to go hard on treating patients and giving them lots of antibiotics to save their lives. But in the modern clinical environment, there is a challenge to that, and that challenge is antimicrobial stewardship. As I mentioned, giving large amounts of meropenem to patients that may or may not have sepsis is driving the emergence of multi-resistant organisms, of crow. We have our own Leicester-grown crow called Oxa48, and we cannot go forward in this way forever because we will run out of antibiotics. So this was particularly the reason why NICE have looked at what we should be doing in patients with sepsis. So last year in March, updated version of NICE Clinical Guideline 51 was released by NICE to moderate what's going on with the clinical management of patients with sepsis. In a nutshell, it's a lot more complicated, which presents its own challenges. The UK Sepsis Trust have distilled this down, and I've got a little graphic that helps illustrate what we should be doing now. And it's essentially to stratify patients into high risk and intermediate risk patients with sepsis. And the intermediate risk ones we should spend more time clarifying if there is an underlying infection or not, and where it might be coming from, and treating with more targeted antibiotics. So this is what it kind of looks like. So obviously, if there's a suspicion of sepsis, of a new infection, and a patient that looks unwell or has other risk factors, then really what we should be thinking is about measuring a serum lactate and then calculating a NEWS score. And then the NEWS score forms the foundation of the level of risk to the patient. So anyone that has a NEWS of 7 or more is immediately high risk, and they should be treated as we have always, with a sepsis 6 within an hour and aggressive broad spectrum antibiotics as soon as possible. So this would include patients with septic shock, obviously, and that patient group does not change. What does change is the patients with NEWS scores that are slightly lower, so 5 to 6. So previously, we probably would have treated these patients aggressively within an hour. We're now suggesting that maybe we should take a little bit more time to think about it. And in those patients, look and think a bit more, discuss with the senior decision maker about whether there is an infection or not, and then treat with an appropriate antibiotic if required. But that should all be done. That process should be completed within 3 hours. Now, there are some very, very important caveats to all of this. So the first one, as I mentioned, the importance of mottling or ashen skin or other skin changes or a deterioration since the last assessment. So someone that's trending downwards, or someone that's deteriorated despite having initial treatment, or somebody that has got an elevated lactate or an acute kidney injury. So if any of those criteria are satisfied, then our patients are bumped up a notch. So essentially anyone with a NEWS of 5 or 6 and one of those criteria becomes high risk. Anyone with a NEWS of 1 to 4, so a very low NEWS score, if they have one of those criteria, they become intermediate, moderate risk. Okay, so it kind of shows the importance of things like mottling and assessing for it, because it changes how aggressively we should treat these patients going forward in the future. Okay, so that in a nutshell is what the big change is. This presents huge challenges to the delivery on the shop floor and communicating this out. In UHL, we are in the process of taking this forward, trying to work with Nerve Centre to get something in on this, but training everybody to assess for things like mottling is going to be hard, and a particular challenge, I think, to rolling this new guidance out. So what kind of resources do we have available for treating patients in ward areas? So obviously on the right, the DART service are there to help deliver immediate treatment. I mentioned the peripheral NORAD, but obviously they can help with all factors around management of sepsis. Top left, sepsis boxes there in the resus trolleys on all ward areas, and in it contains everything you need to deliver the sepsis 6. So if you are a doctor working in a ward and you need to give the sepsis 6, get that out, because it's going to help speed up the delivery. And I mentioned also Nerve Centre alerts, which are still a bit clunky, if I'm honest, but they're there to flag and prioritise patients that may be developing sepsis. The other cornerstone of where we are with managing sepsis is source control, and loads of patients that come our way require source control, some form of surgical intervention, and really this is probably as timely as doing the sepsis 6, certainly getting things initiated. So what the College of Surgeons says about septic shock is that the control of the source of surgery or other means should be immediate and underway within 3 hours. So this is from the beginning of a patient developing septic shock. So getting a surgical diagnosis, getting the appropriate scans done, and all of that should be done within that 3-hour period. This is the definition of a Cat 2 patient on theatres, but by the time the patients come to be booked, they effectively become a Cat 1. So this will be for patients like the picture there of necrotizing fasciitis, but also the patient with a perforation and septic shock, for example. Patients that are slightly less sick, that have red flash sepsis, the timeline should be 6 hours. And again, that can be quite difficult to adhere to. So it requires, I think, a drive from probably from us in intensive care and anaesthetics to help make these things happen when we need to. What we shouldn't be doing is admitting patients for resuscitation or observation overnight and for surgery in the morning. The other thing that the Surviving Sepsis campaign says about source control is that it should be essentially as minimally invasive as possible. So if there are 2 options and one involves interventional radiology drainage versus surgery, then we are probably needing to go down the interventional radiology route as a preference if there is one. IV indwelling devices is the other thing. Obviously, they need to be removed as soon as possible if you think they are the source. From a pragmatic point of view, if that's the only source of IV access, then and you can't establish another access within a prompt period of time, then you can use that access to give that first dose of IV antibiotics. Okay, so don't feel it's totally out of bounds if you have to give antibiotics or resuscitation. And the other option obviously is intraosseous, but yeah, okay. So in the ICU, just talking about antimicrobials. So as most of you that have worked on the unit will probably know, patients come in that have got sepsis tend to be on some form of empiric broad spectrum agent, usually tazocin or meropenem or something like that. Blood cultures go off, come back, we get a more targeted, we get an organism identified with sensitivities, and we're able to target within a few days and hopefully de-escalate things. So that's a really important part of stewardship. In certain situations when there's undrained abscesses or persistent areas of infection deep in a lung, staphylococcal infections will be going on for much longer. But all of our therapies should be reviewed daily, and we have a microbiologist to help do that with us. But we should be constantly thinking about de-escalating our antibiotics and saying whether they're necessary or not. Now, procalcitonin is sort of mentioned a lot in communications about the diagnosis of sepsis, but it's probably not really very good at identifying patients with sepsis, but we can use it to maybe de-escalate patients that we have on antibiotics that we can't really be sure if they've got an infection or not. The other thing in ITU patients that we need to think about hard is fungal infections, because most of our patients will have some kind of risk factor for a fungal infection, either indwelling catheter, pancreatitis, abdominal surgery, just been debilitated for ages, or have a lot of candidemia or candidal colonization. So all of these things will tip the balance of possibly treating a fungal infection. Obviously, we use beta-D-glucan to help with that, but there is a wide range of where we're not uncertainty in terms of what the number tells us. So again, we're often guided by microbiologists on that. Sorry about that. Therapy is an extension of what we recommended in ED or initial management. Really, is to use crystalloids. If you're giving lots of crystalloids, most of us, I think, would consider adding in a bit of albumin to help with resuscitation, but it shouldn't be albumin based, and we shouldn't use starches or gelatins. That seems to be fairly well set. Okay. As you saw in the clinical case, noradrenaline is the first line vasopressor. Vasopressin we often have to add on the second line, and possibly adrenaline, particularly if you think there's a problem with cardiac function. Never use dopamine these days. I know it's still around in some places. Dobutamine is listed in the Surviving Sepsis campaign, but we don't really use it that much at all in this country, particularly in Leicester, I think. You should titrate really towards endpoints reflecting perfusion. You can easily overcook a vasopressor in somebody that's underfilled with fluid, and that can cause a vicious cycle where the patients become more and more acidemic. So we always have to constantly check that we've adequately filled our patients, and look at how the patient's responding to increased doses of vasopressors. Obviously, invasive arterial blood pressure is required. In some patients, there's emerging evidence that the use of beta blockers is advantageous. I think you have to be cautious with this. As I mentioned, they have to be fluid filled first. And patients with significant tachycardias or tachyarrhythmias may benefit from cardioselective beta blockers used in very controlled senior-led situations. And I know esmolol and landiolol have been used a lot in this kind of environment, and they can help improve the cardiovascular status of a patient. Other adjunct steroids, I mean, most of you know, I think, that we probably give in patients with septic shock on a significant amount of noradrenaline, hydrocortisone. The original work on all of this used nasogastric fludrocortisone as well, and that kind of fell out of the way we did things, but there is probably evidence now to support that we should actually be adding fludrocortisone to these patients. Transfusion triggers of 70, I think, is not news to anyone. That's what we'd use traditionally in ICU. Yeah, the rest of it is fairly standard stuff. So organ dysfunction. Most of what we do in ICU with septic patients, we don't have a magic treatment for sepsis per se. We don't reach into the cupboard and say there is the magic treatment that we need to give. Most of it is supportive, and it's supportive of organ dysfunction. So respiratory failure, and the main complication is ARDS. So we often have to go towards ARDS protocols, towards increasing PEEP, reducing tidal volumes, permissive hypoxia, hypocarbia, thinking about APRV, thinking about proning patients, and the extreme situations, thinking about ECMO. As we've heard, septic shock, septic cardiomyopathy, microvascular failure, this is a big deal. Microvascular failure secondary to microvascular thrombosis is extremely difficult to manage, and the ways around dealing with that often center around early recognition and management to prevent this happening in the first place, because once it becomes established, the patients start to lose limbs, become at high risk of death, and go into renal failure. The associated thing with that is the consumptive coagulopathy and consumption of platelets. So we'll often see a tanking platelet count suggestive of evolving mottling, purpura fulminans that can evolve into, and this is often associated with the platelet count disappearing. And as I mentioned, in certain types of sepsis, particularly Group A, invasive Group A strep, also meningococcal disease and other gram-negative infections, ischemic limbs, which is a a multifactorial issue really associated with treatment and the microvascular thrombosis and thrombosis that occurs, but also high doses of vasopressors that would reduce perfusion to the limbs, and they can become ischemic and necrotic. Acute renal failure, about 80% of patients with septic shock could develop some form of acute renal failure requiring renal replacement therapy, plus or minus additional bicarbonate for severe metabolic acidosis as well. These patients then can go on to developing long-term chronic renal impairment. Septic encephalopathy, so starting with agitation and confusion early on in the disease, and then delirium that we see in ICU, and that can then move forward towards a more established and chronic cognitive impairment that the patient then takes forward long term. So this can actually be quite a bad problem. Overwhelming sepsis, again, which we saw in the clinical case, can cause marrow suppression and overwhelm the marrow, affect obviously platelet count, but also the white cell count can be really very low, and then put the patient at high risk of secondary infections on the ICU. As a result of the sort of generalized lack of perfusion, bowel and hepatic ischemia. So that's just a short list of the devastating things that sepsis can cause. Longer term then, so mortality, depending on the magnitude of sepsis per se, anything from 15 to 30%. Septic shock, 40 to 50%. When you get additional organ dysfunctions, that obviously goes up to 50, 60, 70, 80% once you've got 4 or 5 organ failures. Patients that survive, about 5% end up on long-term renal replacement therapy. 5 to 10% have some form of digit or limb loss associated with ischemic limbs. I mentioned the septic encephalopathy. Post-sepsis syndrome now is becoming more and more recognised, this sort of complex web of a susceptibility to further infections, viral illnesses, chronic fatigue, and psychological problems. Post-traumatic stress disorder, because of obviously the intensity of the treatment and how unwell patients have been. And if there's been any chronic any acute lung damage, that can go into a chronic disease. So I'm going to start to wrap up now. I know it's a fairly quick whistle-stop tour of things, but further resources. I mentioned the Surviving Sepsis campaign. That goes into a lot more detail about the evidence that's out there and the recommendations for treatment of patients with sepsis in ICU. The UK Sepsis Trust has got lots of resources, and they're constantly updated on based on new guidance. That is primarily about the pre-intensive care management, and they've got sections on adults, children, neonates, community, you name it. And the nice guidance that I mentioned there as well. So that's another detailed document that kind of outlines the pre-ICU care predominantly for patients that are presenting to us. Okay. So just to summarize and just pull out some of the really important things. Now, if you are a junior doctor that's working in the front line in ED or on a ward, anyone that's deteriorating, you should think about sepsis in all of those and either accept or reject it. And if you're accepting it, you should be thinking about doing the sepsis 6 and getting some senior review. If you're working in ICU and you get a referral about a patient with sepsis, while they are on the phone to you, you should be asking if the sepsis 6 has been done. Okay. So from ICU should be proactive in making sure that the right things have been done to these patients. It is because the best opportunity to save life, reduce morbidity, reduce psychological problems is in that early recognition and immediate management. That's why it's so important, and it will make our lives so much easier because the patients won't be so unwell if they have to come to us. As I mentioned, as the clinical case demonstrates, as NICE has suggested with the new guidance, skin changes are really important and we should be looking for mottling. Where do you look? Well, first of all, hands and feet, the capillary refill times might start to become abnormal, but you should pull the sheet back and look at the patient's legs in anyone that you review. Mottling tends to appear around the knee. It's graded, so grade 1 would be just around the knee, up to grade 5, which is extending up into the groin and onto the abdomen. Grade 5 mottling is associated with a 100% mortality. Grade 1 mottling, I think it's about 20%. Okay, so this is really important and it's part of the future of assessing patients with sepsis. The other thing, obviously, that we can influence is source control, and it's urgent, and everyone needs to get the message that these patients, if they need source control, it needs to be done as soon as reasonably possible. Getting to that point, there can be all sorts of challenges in moving patients around, getting imaging done, getting decisions, but these things need to be expedited and need to work as a team to make sure that happens. As I've mentioned, if someone's hypotensive after resuscitation in the emergency department and they need to come to ITU, we should be starting them on peripheral noradrenaline. Care and antimicrobial stewardship and making sure we're giving the right antibiotics to these patients means that we have to work closely with microbiology and be tuned into any emerging results that we might be getting. As I guess you've worked out, and by working in ICU, most of the care that we do is supportive, in organ support, to buy time, to help patients to get better for themselves. We have no magic treatment for sepsis per se. It doesn't exist. But what we can do is keep them alive until the patients themselves can get themselves better. There are potentially long-term, sometimes life-changing impacts for these patients, as I've illustrated. And I guess working in the ICU follow-up clinic, you'll see that a lot. Okay. Thank you, everyone. We've got a bit of time for questions if anyone wants to raise any particular issues. Fiona from Dart, I can see you're there. I've mentioned peripheral NORAD a few times. Any thoughts on it yourself? No? Anyone given peripheral noradrenaline in ED? Mike?
No, I'm just saying I've given it an ED.
Okay. Yeah, I put my hand up as well. Okay, are there any other points anyone wants to raise?
Do you think we're getting better at sepsis management?
I would say, depending on what timeline you're talking about, Mike, compared to 20 years ago, most definitely. You know, there were cases of meningococcal septicemia that waited 6-8 hours for antibiotics, and they often died. In the past couple of years, I think, and Fiona, I'm sure, will be able to back this one up, we've plateaued or dipped a bit. And I think there's probably multiple factors involved there. One of them is to do with how busy our emergency department is and the lack of redundancy in the system, patients on the back of ambulances, that kind of thing. So the time to getting patients reviewed and treated there's often a delay. There was a recent case just before Christmas that came to us, very similar to the case that I presented, who came in with a young woman that came in with a severe infection and walked in, and it was 3 or 4 hours before she was even moved into resus. She was sat in the waiting room. Now that's a bit of an extreme example, but I think the pressures that the NHS are on is not helping the delivery of the treatment that these patients need. So I think things have dipped. They got really good in 2017, and I think we have fallen back from that position. Okay, well, thank you, everyone. Nice to talk to you, and yeah, enjoy the rest of your day.